Hello everyone, welcome back to Doctor's Desk. Today I'll be discussing Acute Respiratory Distress Syndrome or ARDS. So I have gone through Harrison and other standard references and I have taken the right points and summed up them into one PPT so that you get a clear and concise understanding of this topic. So let's get started. So what is ARDS? It's basically a clinical syndrome that presents with three hallmark features. One, shortness of breath. Second, hypoxemia. Third, bilateral lung infiltrates. So all of this eventually leads to respiratory failure. So ARDS is a type 1 respiratory failure. So the etiologies are classified as direct lung injury and indirect lung injury. The examples are given there. Direct examples are pneumonia, aspiration of gastric contents, pulmonary contusion, toxic inhalational injury, and indirect causes include sepsis, pancreatitis, trauma, massive blood transfusion, or a shock. So we use a Berlin definition of ARDS as a diagnostic criteria. The key criteria: the onset must be within 1 week of the trigger. The chest imaging should show bilateral opacities not explained by the collapse or effusion, and respiratory failure should not be due to heart failure or fluid overload. And finally, hypoxemia is graded based on PaO2 and FiO2 ratio. This gives us mild, moderate, or severe ARDS. Usually they play with these numbers in exams: mild, moderate, and severe. So mild is 200 mmHg, moderate is 100 mmHg, and severe is less than 100 mmHg. This is a chest radiograph showing the bilateral opacities, which is seen in the exudative phase of ARDS. So there are three phases of ARDS. So exudative phase, proliferative phase, and fibrotic phase. So first we'll see about the exudative phase. What actually happens in exudative phase? So the alveolar capillary barrier gets damaged. This allows the protein-rich fluid to leak into the alveoli. Neutrophils rush in and releasing toxic mediators. Then plasma proteins and dead cells combine with surfactant dysfunction to form hyaline membranes. So that eventually it will lead to pulmonary hypertension. So the clinical features include dyspnea, tachypnea, shallow breathing, hypoxemia due to perfusion mismatch, then decrease in lung compliance. The lung will be stiff. Then the chest X-ray will show bilateral opacities without cardiomegaly or pleural effusion. So this phase is very important because it should recognize the patient early and give them proper management to prevent progression. And the second phase is proliferative phase, which is actually the repair phase. By second week, many patients enter into the proliferative or repair phase. Here the inflammation starts and starts to settle down. Neutrophils are replaced by lymphocytes, and type 2 pneumocytes proliferate. They produce surfactant and also differentiate into type 1 cells, trying to restore the alveolar lining. Clinically, some patients improve, the oxygenation gets better, compliance improves, but others continue to deteriorate. So this, if this phase gets deteriorated, this eventually turns into a fibrotic phase. So this phase is the turning point for the patient. So here the lung undergoes a permanent scarring, and alveolar walls are destroyed, replaced by fibrosis. We can see honeycombing and bulle-like changes in the lung. Then pulmonary vessels also get obliterated, leading to pulmonary hypertension. Clinically, the patients remain severely hypoxemic, often requiring long-term ventilation or oxygenation. This represents the chronic or often irreversible lung damage. So this is a summarization of the three phases. Usually the exudative phase is for 7 days, and then proliferative is next 7 days, like 7 to 21 days, and fibrotic is more than 3 weeks. So now we go to the management. The first principle is always treating the underlying cause, like pneumonia, sepsis, aspiration, or trauma, or pancreatitis. Then at the same time, we should provide good ICU supportive care, like the bundled care to prevent venous thromboembolism, give GI prophylaxis, prevent aspiration, minimize sedation, and provide eternal nutrition. These steps don't treat ARDS directly, but they prevent the further complications. So next, this mechanical ventilation is one of the most important settings in ARDS. Patients eventually require ventilatory support in ARDS. The golden rule is lung protective ventilation. We should use a low tidal volume, like 6 ml per kg, predicted body weight. Then we have to keep the plateau pressure below 30 centimeter H2O. Then we have to apply positive end expiratory pressure to prevent alveolar collapse. So we should also avoid giving high FiO2 for longer periods to prevent oxygen toxicity. So we should avoid a ventilator induced lung injury, which I have said in the previous video. You can check in the given link. Then ventilation can damage the lung via the volume trauma. So you can see this graph. The y-axis tells the volume, then x-axis tells the pressure. This is a volume pressure relationship. You can see the alveoli during this volume and pressure gets collapsed. As the pressure increases, you can see the alveolar sizing gets distended. As the pressure gets increased or above the limit, it gets over distended and occurs volume trauma. Then three things happen in ventilator induced lung injury, like volume trauma, barotrauma, or atelectotrauma. So also keeping this alveoli in repetitive alveolar collapse size or shape, it will lead to atelectotrauma. Next, in patients with ARDS, prone position has proven to be a game changer. By turning the patient into their stomach, the dependent areas of the lungs get better aeration and perfusion matching improves. In 2013, it showed a significant 2013 study showed a significant reduction in mortality in patients with PaO2 and FiO2 less than 150 who were prone early. So prone position is also one of the standard care of ARDS. Next comes the fluid management. It's also a crucial principle in ARDS management. So in ARDS, these capillaries are leaky, so excess fluids only worsen pulmonary edema. The strategy is keeping the filling pressures low with the diuretics and fluid restrictions. This improves oxygenation and reduces ventilation duration. So we should avoid excess fluid restriction, or else it may cause hypotension or renal hypoperfusion. And in some patients with ARDS, sedation is not enough. They keep fighting the ventilator. In these cases, short-term neuromuscular blockade with agents like cistracurium can help achieve synchrony and improve outcomes, but it is not recommended routinely, only when there is dyssynchrony despite a good sedation. Then glucocorticoids, steroids have been tested extensively in ARDS, but routinely it's not recommended. They may be considered in patients with sepsis with refractory shock. Low dose hydrocortisone 200 mg per day is given. Otherwise, its glucocorticoids are not useful. So other therapies, surfactant replacement, it is usually used in a pediatric age group. Then inhaled vasodilators, nitric oxide, epoprostenol is a transient oxygenation improvement but no survival benefit. Then recruitment maneuvers and alternative ventilation modes like um, HFOB haven't shown consistent benefit. Then ECMO, which is extracorporeal membrane oxygenation, used in refractory severe ARDS. It is not first line, but it is used in a rescue therapy in selected patients. So then we come to the summarization of the management. So first we have to treat the underlying cause, pneumonia, sepsis and trauma. Second, we have to give supportive ICU care like venous thromboembolism prophylaxis, then nutrition, then infection control. Then we have to make the give the lung protective ventilation. Then mainly the mechanical ventilation settings like low tidal volume 6 ml per kg predicted body weight, then platform pressure less than 30 centimeter of water, PEP titration, then conservative fluid management, prone positioning, then neuromuscular blockade. Then you have to consider ECMO in refractory hypoxemia patients. Then we have to avoid routine steroids and surfactant or inhaled NO. So that brings us to the end of this session on ARDS. Thank you for listening, and I hope this session made the concepts clear. If you found this helpful, please do subscribe to Doctor's Desk for more clinical lectures.